Good morning, and thank you for joining us on this expert panel discussion on data sharing during public health emergencies and the prospects for bilateral cooperation in tackling new infectious diseases in the future. Sorry to disappoint, but I'm not actually Champa Patel, but it really is a pleasure to be chairing this discussion today. I'm Emma Ross, and I'm a Senior Research Fellow in the Centre for Universal Health at Chatham House. At Chatham House, we are really interested in the issue of international solidarity in this pandemic. And to explore the issues around solidarity among scientists, we have on today's panel Sir Patrick Vallance, the Chief Scientific Advisor and Head of the Government Science and Engineering profession for the UK, and Dr. Yasuhiro Suzuki, who is an advisor to the Minister at the Ministry of Health, Labour and Welfare in Japan, and he has played a key role in the country's response to COVID-19 since its outbreak. He's previously served as Japan's Chief Medical and Global Health Officer and Vice Minister for Health. Just to set the scene a bit, the incredibly fast development of the first vaccines against COVID-19 is just one result of the unprecedented level of global scientific solidarity that's been going on during this pandemic, with the sharing of data, virus genomes, information, other scientific resources and experience. And such cooperation has not only accelerated vaccines, but it's also helped spread understanding of the virus and how it behaves. It's helped the investigation and prediction of disease spread and the identification of what works and what doesn't in terms of interventions. And we will be hearing a little bit more about that just in a minute. But today we're going to talk about what the experience has been with these from the Japanese and the UK perspectives, and what we can take from the experience to build closer links between countries, specifically the UK and Japan, that will enable us to better face the next global public health threat. The discussion is held in partnership with the Embassy of Japan in the UK and Japan House London. So before we dive into the conversation, I'd like to ask Michael Houlihan, Director General of Japan House London, our host, to offer some brief remarks. So Michael, over to you.
Thank you, Emma, and thank you to everyone for joining us this morning at Japan House London online. Japan House is privileged to be hosting another session in a series of events organised by Chatham House and the Embassy of Japan in the UK. By way of introduction, for those of you who don't know about Japan House, it's located on Kensington High Street in London. It's arranged across 3 floors, gives visitors the opportunity to discover, learn about, and engage with Japan, offering a range of varied cultural experiences such as exhibitions, events, workshops, a library, a shop, travel advice, and gastronomy. It seeks really to build a deeper bridge of understanding and a legacy of relationships between the UK and Japan. As we see this morning, Japan House is also a forum for the exchange of ideas and conversations between the 2 nations across a very wide range of important topics. This is all part of a vigorous online presence that since March has seen over 30 Japan House online events, including manga and craft workshops through to 3D virtual exhibition tours. So I'd ask you to check out our website, especially as our exhibition just closed today as a result of the higher level of tier restrictions here in London today. As a historian, I suppose I've been intrigued by the ways in which earlier pandemics have impacted upon culture and even changed the course of history. Whilst the full assessment of the current outbreak's impact may have to wait, interestingly, we've already seen that culture has had an impact upon the ways in which different nations have responded across the globe. In a sense, cultural diversity can be described as the different ways in which different peoples find different solutions to the experiences, aspirations, challenges, and condition of everyday life, wherever they are and whatever their history. Perhaps today, more than ever, there's a real need to share our understanding and solutions as we all face the single global challenge of COVID-19. So I'm particularly looking forward to delving into the guts of these issues and how we share experiences. So thank you to our speakers, thank you to the audience, and I hope eventually I will see you all at Japan House one day. Thank you. Emma.
Thank you, Michael. Hero, I'd like to invite you to start. So over to you.
Good morning, Emma. I'll be talking about the Japanese status of pandemic and Japanese programs to contain the pandemic and comparison between the UK and Japan in terms of the pandemic and the key lessons for future. This is the waves of different level pandemic starting from April. In April, we have experienced the medium-sized of pandemic, mainly perhaps imported from Europe, North America, because during the spring vacation period, people will be going to Europe and United States and coming back to Japan. And then the virus will be spread amongst us. And then we have, on 7th of April, we have declaration of state of emergency. Will be lasted until 25th of May. And we have somehow successful to manage the contain the pandemic. But in July, again, the second surge of wave happened, mainly because we had the kind of continuing low-level transmission in busy downtown district, night bars and pubs. And thanks to the collaboration of Japanese people to avoid the very risky and contagious situations, we have somehow managed to control the pandemic. But then again, starting from October, we are having the third and largest pandemic happening right now. Can I have the next slide, please? But in comparison between UK and Japan, the column A is the cumulative positive cases per 100,000 population. UK is about 2,800. Japan is about 140. So it's about 20 times difference. And number two, the death of positive cases cumulative per 100,000 population. UK is around 100. Japan is around 2. So difference is about 50 times. And column C, case fatality rate, which is B divided by A. UK about 3.4%, and Japan is about 1.5%. So it's about 2.5 differences. And the D is the actual tests conducted per population 100,000. UK is around 70,000. Japan is 3,000. I would say the size of the PCR testing is somehow related to the size of infection. So Japanese approach to COVID-19, threefold. Number one is test and trace. We have a cluster-based approach focusing on retrospective contact tracing, which means from whom, if I were the patient, from whom I was infected, in addition to whom I may be infected. Number two, these surveys will be conducted by public health centers. We have around 400 public health centers across the country, and public health nurses will be conducting the survey. And we have identified the 3 C's, which is closed spaces or crowded places, or close contact settings, which is very dangerous and contagious situation. And we asked people to avoid these type of places. Number two is prevention from spreading. We have isolated the cases to hospitals or designated facilities such as ourselves. And we have asked the people in close contact to stay at home at least for 2 weeks for self-isolation. And lastly, as I mentioned, we have declared the state of emergency starting from April and in May. But I would say this is a kind of soft lockdown, not the hard lockdown, as you can see in UK or Germany or France, because we have no penalty for going out during the state of emergency period. We have asked the people to stay at home. We have asked the restaurant to limit the operating hours to 22 hours. Next slide, please. This is the health data management system, especially designed for COVID-19, called HACIS, Health Center Real-Time Information Sharing System, which is shared between three different sectors: doctors, patients, and health centers, local authorities, and government. And doctors will be inputting the basic health information to the patients. And patients will be reporting their own health conditions through smartphone applications. And the government will be collecting the information from these sources immediately. So this is the kind of situation we have introduced after the pandemic. So this is my last slide. Mainly 2 points. First, you need to specify the factors coming from the data analysis which make the infectious status difference amongst countries. Is it because of the ethnicity, or is it because of the geography, or is it because of the culture? Because in some theory in Japan, we not kiss or hug for greeting, we bow each other. That would be avoiding the close contact. In terms of the cross geography, it is said that in East Asia, in some years ago, corona flu spread, and many people infected by corona viruses, not the COVID-19, but somehow we have some type of cross immunity. And then it is preventing the people get serious illness or to get mortal. So these type of understanding the reasons for differences will be very important. And the next issue is if we're going to compare data, we have to have the standardized means for collecting the data and harmonizing a definition of some specific case terminology. For instance, in terms of mortality, some countries are reporting the death only the COVID-19 was the main cause of death. But in my country, Japan, any death related to COVID-19, even though they died from traffic accidents, if they are positive for PCR, that will be recorded as somehow related death of COVID-19. In terms of the severely ill, some countries are reporting with patients with less oxygen level in blood, but some countries are reporting the patients with ECMO or mechanical ventilators. And in terms of the case patient definition, some countries are reporting all patients, but some countries are reporting only the patients in hospitals. So if you compare the data across countries, you have to have the harmonized definition of this case terminology. Otherwise, you are comparing apples with oranges. So these are my conclusions. Thank you, Emma.
Thank you, Hiro. Lots to follow up on that, but I will wait until Patrick has shared his thoughts. So over to you, Patrick.
Thank you very much, and thanks, Hiro, for those words, and thanks also for the collaboration that we've had with Japan over this period, and we've certainly learned a lot from the way that you've done things. So data was an issue from day one. Going back into January, questions were, how transmissible is this virus? What's the case fatality rate? What's the infection fatality rate? What's the R value that you would expect of this infection? And it was really difficult to get hold of data. So there was definitely a problem of data access early on. And then there was an early example of good data sharing, which was the sequence of the virus, which came out relatively quickly and was shared globally. So data access was an issue from day one. And reflecting on what happened around that time, the rather old-fashioned but incredibly important thing happened, which is we talked to colleagues. And that became a very important part of how information was shared, because data sharing was quite difficult, but speaking to colleagues around the world was the way that I think a lot of contacts were made and a lot of information was shared. In the UK, early on, we activated the Science Advice Group for Emergencies, SAGE, which has a series of subgroups, and one of those is a modelling subgroup. What is very clear is that we had relatively poor situational awareness. Data access was slow, quite difficult to get data flowing through the system. Data quality was not always as good as it should have been, and data linkage and interoperability was a problem in terms of where cases were occurring, how cases were potentially linked to each other, what the occupation of people was, postcode, housing, the sorts of things that allow you to get a better handle on what this is epidemic is really doing were difficult to do early on. They're very, very much better now, and that system's in place. But the truth is the systems weren't in place to be able to do that easily at the beginning. And that was a problem for accessing and monitoring the epidemic, but also a problem, of course, for researchers to be able to do other things to give new information. So monitoring spread and speed of spread was difficult early on. Some of the key things that were put in place early on, which I believe have been important and will be important going forward, first of all, was a big effort on viral genomic sequencing. And that was incredibly important. It got set up early, and it's an area, I think, in which data sharing globally has been really, really good. And that all goes into one place. It's all accessible to scientists across the world. And the UK certainly did a vast number of the sequences that are now in the public domain. At one point, it was 60% of all the world's sequences. It turned out to be incredibly important for us understanding what happened in the UK, because through the genomic sequencing, what became very evident was that the UK had a very wide seeding of infection at some point in February and early March, largely not from the places that you would expect, which would have been China and the East, where there was the origin, but actually from other countries in Europe. So most of the seeding came from Spain, Italy, and France, and was almost simultaneous right the way across the UK. So genomics has been important. The second domestic area that was important was setting up an infection survey to be able to randomly sample the population across the UK, the Office for National Statistics survey, which gave weekly and does give weekly information on a random big sample as to what's happening with the disease. That has been absolutely instrumental in terms of understanding how the disease has spread, in which direction it's moving in, up or down. And just as in Japan, we've had several waves of this that have gone up and down. That survey has been important. And then others, such as being able to measure antibody responses and share those. A key thing that was set up, which was really important, was the notion of a biosecurity center that was a data hub for all of the information in the UK. It's so-called Joint Biosecurity Center, the JBC. That was an important initiative to try and get this properly under control in the Department of Health. But for all the reasons that Hiro said, it's still very difficult to do true international comparisons because of differences in the way data are collected, defined, and of course the data collection is only part of it. The analytics and the information that comes out of that, of course, is what is key. So what were the issues that we saw, just to sort of summarize that? Time lag, access to data, data ownership issues, data sharing agreements, differences in collection, all meant that actually data access was not as good as it should be, and not as good as it is now, and indeed should be going forward. So these are very key issues, and I want to come back to a rather contemporary point in relation to that in just a minute. And it's not just health data, it's the notion of sharing data across other things such as transport, mobility, housing, issues of social care. It's the interoperability between those data sets which becomes very important. So just to touch on the point that Hiro raised, why is it that different countries may have done or have done differently in terms of the outcome? One is the seeding and the dose, so that different countries got different levels of infection before it was evident. That definitely will be part of it. The second relates to demography, I suspect, and issues of inequality, issues of health inequality, issues of demographic makeup of a society, both in terms of comorbidities and age. There will be many factors in there that will be important. A third is the physical environment. So that's issues like the types of places people live and work in, the types of environment, as Hiro said, where spread occurs most effectively. And we've got rather poor data on some of that information. We know, for example, multi-generational households become a risk. And the fourth I'd pick out is the size of both a healthcare system in a country and the preparedness of a public health system. And I think what's really striking is that in the East in particular, public health systems were well set up for test and trace systems, which you can't just stand up overnight. And they were well set up because of the preparation that took place following MERS and SARS. And I think that's an important point. And then there's all sorts of other things that we do not understand as to why differences have occurred. And indeed, it's quite difficult to look at for the reasons of data standardization. Let me end with the contemporary point. The data sharing and ability to look across data has been crucial for managing the epidemic. It is going to be absolutely crucial for understanding vaccines. And so this discussion of how countries can share between them is important now, because as vaccines roll out, we need to really understand the effects on transmission, on disease, on severity, on different age groups. And we need to understand, of course, issues such as safety and when vaccine effect wears off. So I think there's a very live question around data sharing now, which is crucial for countries to get together on. I think I'll stop there, Emma, because I suspect the best use of time is the questions, not me speaking.
Okay, thank you, Patrick. Again, a lot more to dive into there. Before I go into my questions, I just want to do catch up with housekeeping, which I forgot to say before. Of course, this event is on the record, and please do submit questions to our speakers. If you want to ask questions, please put them in the Q&A function on Zoom. You can also upvote ones that you particularly like, and upvoted tends to make them more likely to be selected. But please do start fielding questions whenever you'd like. So I'm going to come actually to both of you, because you've both mentioned this, on the harmonization of data collection and the way things are classed, how you count cases and deaths particularly, and what that means for the comparison of numbers. As we all know, there's been a huge discussion throughout the pandemic of, look at that country over there, how many cases they've got, how many deaths, and that's been used to judge they've been doing a rubbish job or they've been doing a great job because their numbers look low. And it has been said that there are huge differences in the way these things are counted. And you've both talked about harmonization of data being desirable or a need to standardize these definitions. But I wanted to ask, first of all, is there really any hope of getting a single system? Is it possible? And what are the benefits of it? Is there any effort to do that? Who would be in charge of doing it? And if it's not being done now, is this something we need to do after the pandemic to have in place for the next time? Because this is not the first health emergency where this issue has come up on standardized definitions. First of all, do you think there's any ever hope of achieving that? Or is it something that, of course, would be great, but let's be realistic? Hero, do you want to go first?
Yes.
And then I'll swap.
I think we do have hope that future harmonization will be done for the benefit of all people in all countries. And I truly believe there is room for World Health Organization. There are reasons for existence. They have occasional meetings and the executive board meetings and World Health Assemblies. And they have the legally binding IHR, which is the International Health Regulations. So you could provide the mode of collecting data and the definition of in each case terminology in those international health regulations. And we are starting to revisiting the international health regulations because we had some problems in terms of the reporting of cases in terms of this COVID-19 pandemic. So I'm very hopeful that this will be done early next year, because in January, we are going to have a big session of the executive board meeting of WHO. Thank you.
So Hero, can I just say, are you saying that we may get to a place where no matter what the next emergency is, there will be a standardized way of, if we're going to count cases, we're all counting the same way, the same cutoffs, the same definitions? Can that be done when we don't know what the disease is, or is there a way to put in a system or a framework that you can just adapt when the next thing comes along?
I think we can do it because looking back for the last 20 years, we are having one pandemic cases globally hit for every 4 or 5 years. So we still have some years to prepare for the next wave of pandemic. And we have many, many scientific and academic meetings during that period. And I'm sure that we could achieve our goal in terms of the harmonization.
Okay, Patrick, first of all, do you think this is realistic?
Well, I think Hero's right. There will be progress here, and there are some things that can be done which are more straightforward. I think, though, it is not overall a straightforward problem to do the whole thing. I mean, there are issues of different settings in which death occurs. There are different ways in which countries record deaths from different settings. There are different ways in which they integrate those within countries. And there's definitely been differences in how COVID-related deaths have been recorded, which is why ultimately, probably the only way we're going to be able to look at this in retrospect is to look at total excess deaths in a country and look at it that way, because that will include, of course, all the COVID deaths plus the deaths that may be a consequence of the actions taken to try to stop COVID. So I'm with Hero that this is a very important area and that this is being looked at and there will be progress. I am not sure we're going to get to a situation of perfection with this. I think it's going to be tricky, but we will get better than where we are now.
Okay, and if even if we do make progress, as far as taking lessons from this pandemic for the next time for all of us, do you think there is any way we can really look at, is it fair to judge there are lessons to be learned and good things we can find from that country because their numbers were low and that country's numbers were high, so therefore all we can learn is what they did wrong? What do we do with the situation we have now of how are we going to judge what is a good response or what has been a successful response or not successful response, if not by the numbers of what the outcome was?
Yes, I do think we're going to have to look at that in terms of numbers of outcome. And it's very clear there are different outcomes in different countries already. You can see that. You don't need to get to great nth degree detail of deaths in order to be able to see that. Now, the reasons for that, I think, are much more complicated. And of course, we're not done yet. So unfortunately, this is still going on. And we can see it in Europe now. Countries that actually did well first time round and now suddenly having a different problem to the one they saw in the first wave, with nothing apparently having changed in that country. So I don't think we can yet look and say that we understand all the lessons. There are some lessons, I think, that are clear, and obviously I've alluded to one already. The preparedness of public health systems, I think, is a critical issue to be able to be in a position and a scale and a funding to be able to respond to this. That is a critical area. But I think we're going to have to wait a bit to understand exactly why things have happened in different countries. And I've given several reasons why I think we may see differences, and Hero's added other ones, including cultural ones. You know, we don't know yet, for example, the relative seeding of infections in different countries. And what we know, for example, in the UK is we got a pretty much simultaneous seeding right across the country. That's very different from for example, in Italy first time round, where they had a very localized seeding in the north of Italy. And so there are things like that that are going to matter. There are demographics, there are issues relating to inequality, housing, physical environments, and so on that will matter. And yes, we're going to have to use the numbers in order to get to the bottom of that.
Okay, Hero, do you want to come back on any of that?
Yes, I think absolutely it's very important to compare the data and learn from the reasons for differences for that. And I would think there are possible 3 reasons for the differences. One is the biomedical reasons, difference of ethnicity and these type of genetic background. And second issue will be the socio-economical issues surrounding the different types of population. And the last one is the different impact of programs. The key issue is we don't know yet relative weight between those three. So we cannot divide the weight into three. That's why we have some difficulty trying to manage the reasons for differences. So if you continue to have data, if you continue to compare data, we will have perhaps in 5 or 10 years, we'll be able to differentiate the weight between those three factors. That's what I think.
Okay, thank you for that. I'm going to move on now to Patrick. I'll start with you on this. I'm interested from both of you what your thoughts are on the relative value of formal platforms for this kind of data and information sharing. And of course, we're talking not just data, but information sharing, knowledge sharing, sharing of all kinds, experience, the relative value of formal platforms and informal networks. Because from experts I've spoken to, they say you cannot underestimate the value of informal relationships, and also that it's probably best that they be forged before an emergency situation, but you can probably still pick it up in a crisis. So I'm interested in your experience with that and your views on the formal platforms versus the informal, and then how the formal networks or the formal platforms have worked or not worked.
My rather boring answer to that, Emma, is of course it's both. The formal platforms are required, and there's been quite a lot done to try and improve those over the course of this pandemic. But it hasn't always worked well. It's not been easy because, as I've already said, it's actually not been easy to get some of those standardized even within a country. So the idea that you can easily do it across has not always been easy. I've given an example where it's been incredibly useful, and that's the genomics one, where it's all happened very, very well. And WHO have set up their platforms to sort of get data on from different countries, which has been a very important part of this. So that's really been important. But I don't think you can in any way overestimate the importance of the informal networks. And we've had regular calls with Japan, for example, but with many other countries where you get under the skin of the data, because the data is one thing, the analysis and the information is important, but actually what that really means in practice is also important. And so I think those networks have been crucial, certainly from a personal perspective. They've been absolutely crucial right the way across the world. And a lot of those were set up in other fora before this. So there are regular meetings of government chief scientific advisors where I got to know my colleagues. There are similar meetings of chief medical officers where people get to know each other. Those have been really important, those pre-existing contacts. And as always in a situation like that, a series of new ones have emerged as well, which have been critical. So we still have, I say we, me and Chris Whitty, the chief medical officer, we have very regular meetings still with countries right the way across the world, our colleagues in those countries, because that's where you get the sort of real information. And it's, I'm afraid, it's not all hard mathematical data. Some of it is just a bit of what's really happening type discussion.
Thank you. The human touch is still in there. Thank God.
It's rather important.
So, Hiro.
Yes, I served also as the Secretary General of COVID-19 Task Force within the Ministry of Health, Japan. And I have witnessed that in the first and second wave of pandemic, the ministers and secretaries have a weekly teleconference comparing data and trying to figure out what would be the right strategy to contain the pandemic. And consecutive senior officials meeting will be held through video conference. And also I recognize there are interactions between Medical Research Council in the UK and AMED in Japan and NIH United States. So I would say official channels of the communication are open and still will be opening. And in terms of the unofficial or informal interactions, I recognize there are a lot of interaction between scientists and academic researchers in US and UK, Japan, and China. But this will be depending upon, as Patrick mentioned, interpersonal relationships between scientists and researchers. Somehow try somehow not the kind of widely spread across many countries, somehow limited to 2 or 3 countries. So the future agenda will be how we could formalize or try to balance between the formal and informal communication and try to strengthen the base for the informal communication channel. Thank you.
Thank you. But before I move on to the audience questions, just a quick one, and that is the international platforms for data and information and knowledge sharing that exist already. What do you both think about where we are with those? Do they leave a lot to be desired? Are they really quite good? Have we got a lot of work to do on them in the inter-pandemic period? What do you think of the platforms that are there for everyone to plug into?
I'm afraid I don't think we have sufficient level of official exchange of data across countries because, of course, we have G7 exchange of data, but it's limited to G7 countries. So for the future pandemic, I think we do have much to desire to expand the level of communication. And we have to prepare in advance of the pandemic. Otherwise, the government and hospitals will be overwhelmed by this pandemic and try to somehow forget about the kind of importance of data exchange.
I agree with that, and I think it ranges from data sharing on surveillance, and I think that's going to be a critical thing going forward, particularly as one thing about zoonotic diseases. So I think there's a whole area there that needs to be bolstered. But there are, as Dr. Suzuki said, as Hiro said, there are many different examples where the platforms are either embryonic or just aren't where we need them to be going forward. So I think it's an area that's going to have to be looked at very, very carefully in 2021.
Okay, thank you both for that. I'm going to cede my ground now to the audience and take the most upvoted question is from Kieran Walters. And this is, I guess we can delve a bit deeper on this. It's aimed at Hiro. To what extent, and Patrick, do the panel think culture is important in this comparison? We've talked already about culture, but maybe we can go a bit deeper. For example, common wearing of face masks in Japan, trust in authority or government to follow rules without enforcement. So I guess, Hiro, why don't you start with the role of the importance of culture in getting a successful response?
Well, I would say the importance of social norms and culture is very important in containing the pandemic. One, as I mentioned, in terms of greeting, we bow each other rather than kiss and hugging. And almost more than 90% of the people are wearing masks, face masks. If you are on the subway in Japan, almost everybody's wearing the face masks. And you cannot go into the subway without wearing the face mask. And the other issue is the peer pressure or your belief in government. Even though the government state of emergency declaration is a kind of soft lockdown, almost 80 or 90% of the people decided not to go out during those periods and limit their outing for buying the daily necessities. So I would think the Japanese culture or East Asian culture are playing a very important role in containing the pandemic.
Thank you. One other thing I wanted to ask, if you agree, this is something several experts, and David Heyman, Mike Ryan, have pointed out that in countries like Japan, a cultural aspect is that the individualism is kind of set aside for the greater good. There's more of a sense of duty towards the other rather than what's in it for me and me, I. Is that a true reflection of the way the culture is, or is that a bit of a wrong stereotype?
Well, I would agree that if you're requested by government something, you'll be looking around and you would do what everybody is doing. So you will be following to everybody. That's, I think, the Japanese very specific and unique aspect of culture. And that's playing a pivotal and very important role in containing the pandemic, I would say.
Okay, Patrick, the role of culture and what has been the how that's played out in the UK.
I've got three observations on this. The first is it's a bit of culture and it's a bit of history. So that I think, you know, one of the things that you see, particularly in some of the countries in the East that were affected by MERS and SARS, is the population were primed to do certain things because they'd seen it before. So there's definitely something about the pre-existing culture, but also the response to what had happened previously. The second is quite early on, an academic contacted me with some modeling, which suggested that if 1/3 more people stayed off work when they got a small upper respiratory tract infection at the beginning of the pandemic, the impact on the total size of the pandemic would have been huge. And so there is definitely, and we know this from all sorts of data, that there are cultural differences in presenteeism versus absenteeism from work in the face of infections, and that will have had an impact. And the third, which I think is intriguing, and I don't know what the reasons for this are, but if you look at Switzerland, it's quite intriguing that the rates of COVID in the different language speaking parts of Switzerland tend to much more closely mirror the countries of the language than they do of Switzerland overall. So, you know, I don't know if that's still true today, but it was at one point in the epidemic true that you could actually see that French speaking Switzerland had numbers similar to France, German speaking Switzerland had numbers similar to Germany, and Italian to Italian. So I think that must tell you that there is something quite important here in terms of cultural aspects to this.
That is really fascinating, actually. Okay, so next up voted question, quite closely behind, is from Charles Clift, and this is about travel restrictions. Hero, how important have restrictions on travel been in limiting the scale of the pandemic in Japan?
Well, I think it was very important to try to ask people not to travel to different prefectures and stay as long as they could at home. And we have now introduced the kind of travel campaign because the travel industry is suffering from the loss of their sales, about 20 or 30 or even 50% as compared to last year. And we have seen the surge of the third wave starting from October, which just coincide with the start of this type of travel campaign. So I would say the limiting or restrictions on travel will somehow have the impact upon how we could contain the threat of diseases in Japan.
Okay, what about the border travel restrictions or the quarantining? Has that been helpful, do you think, in reducing spread?
Yes, I think
and how have you approached it?
Yes, cross-border quarantine is very important for, especially for island countries such as UK and Japan, as compared to continental countries in Europe. Cross-border quarantine is kind of strictly conducted in airports and seaports. And we have recorded every case which is PCR positive at the point of entry. So I think the cross-border quarantine has been very effective so far because Japan is surrounded by sea and you cannot swim across the sea, of course. So I would say this type of issues should be shared with other countries, with island countries such as UK and others.
Yeah, Patrick, we've also had the quarantine requirements for incoming travelers. Do we have any data evaluating how useful that's been or how successful it's been in limiting spread at all, or what's been the impact or the effect of that?
So what we know, and I think this is where the genomics of the virus has been incredibly influential, because you can actually trace where things have come from. And so it's very clear that imported cases become a very important mechanism of spread. They are, of course, most important when the spread within your country is lowest. So once you've got domestic spread, the relative importance of importation becomes much less. But at the beginning, you can see a big impact of imported cases. And similarly, if you look at domestic travel, you can see the importance of domestic travel for spread from high prevalence areas to low prevalence areas. So there's no doubt that you can restrict this if you can restrict that entry. Now, the UK is one of the most connected countries in the world in terms of travel. And I think there's no doubt that that very, very extensive international interconnectivity was quite an important part of early spread into the country. And of course, the only way you can stop that is to have complete border controls to everywhere in the world, which is essentially what New Zealand did. And that would have to be everywhere. And so whereas many countries, and the UK took some quite extensive border control measures early on in relation to China and certain countries in the East where you could see this had happened, by then this had already spread everywhere else. And so the spread came from elsewhere. So I think there's no doubt that spread comes from travel, and controlling that is pretty difficult once it's a pandemic. And it's in terms of magnitude less important the more domestic spread you've got. It becomes a smaller proportion of the total.
Yeah, this has been a really contentious issue, as you both know, with the international health regulations and whether there should be recommendations to close borders and under what circumstances. Do you think there is work to be done, learning any lessons from the COVID experience around the whole issue of what do we do and what do we say about border controls and travel restrictions and travel quarantines and this kind of thing? It seems a little bit of an elephant in the room with the international health regulations and WHO saying we don't recommend you close borders. What is the evidence emerging around what is the epidemiologically correct way to deal with this travel and border situation?
Well, go ahead, Hiro.
Sorry, I think what WHO has been recommending that they are saying that we should not introduce the cross-border restrictions. I don't think that's the right answer for the countries, because on the other hand, WHO commended China to cross the town of Wuhan after the first pandemic. So I think recognizing the importance of travel and trade, but somehow in the process of pandemic, we have to, in a very limited time, have to restrictions in terms of the trade and the movement of people. Otherwise, we are not protecting our people, and we have to have some type of measures according to the international health regulations.
Patrick.
Well, I think the epidemiology is pretty clear, and it's really based on, as I said, viral genomics that tells you that you get a lot of importation. So that the message is quite clear, actually, which is that early on, before you get massive increases in infection domestically, if you can control border entry, you will have an effect.
Okay, so you're saying early on, that means later on when you've got high prevalence, what is the utility?
It's much less important, much less important.
Okay.
Because it just becomes a fraction of the overall problem. So it's not nothing, but your focus of spread then becomes person to person domestically.
And yet in the UK, we still have it. We still have these quarantine requirements with the high prevalence in country. Might that need to be looked at, or is it being looked at?
Well, I mean,
on an ongoing basis.
The advice we've given is that measures for border control are most effective when you're looking at countries with higher prevalence than you have in your own country. That's where it's most useful. In other situations, I mean, in a way, it's obvious. If you're going from somewhere that's very low prevalence to somewhere that's high prevalence, the chance of you importing an infection is much lower than somebody doing it inside the country.
And I guess that hasn't changed over time, that equation. Okay, I'm going to move on to.
It's very interesting to find that when you travel from Japan to UK, you don't have any quarantine period.
Oh, yes, you're
But
a
if you're
travel
traveling from
corridor.
UK to Japan, you'd have 14 days.
Yes,
Sorry.
yes. Okay, there's a question here. In the UK, from Nicholas Webb, it's an upvoted question. In the UK, we've had considerable debate as to the role of devolution in the COVID response. Do the examples from Japan or elsewhere provide a steer on whether centralized or decentralized governance models are better able to tackle the pandemic? So I think, Patrick, first on that, do you think the example of Japan or other countries, evidence on devolved versus decentralized versus centralized?
Well, I think there's pretty clear evidence on things like contact tracing and so on from a number of countries that whilst you may need a sort of central resource to be able to get the whole thing done, much of this is a local activity. I mean, things like contact tracing require local knowledge, local interaction, understanding the community, understanding the geography, understanding, where certain things are happening in a city, so that has to be done locally with a national support system to make sure you've got the infrastructure to do it. So I don't think it's an either or, actually. I think it's important to get that balance right, and important to look at what should be devolved and what should be pushed out in order to make it effective. And I think in any situation like this, local knowledge is actually rather important in order to understand how to manage it.
Hero, your perspective on decentralized versus centralized.
Yes, if you look at the case of United States, I mean, some state governors are not recommending face masks to wear, and these types of differences will perhaps make people very worried about what are the stages of the infection control in those states. But in other case, very centralized government in Europe may not be able to prevent the pandemic at the same time. So being centralized is not the sufficient condition for controlling the pandemic, I would say.
Agree with that.
Okay, the next most upvoted question is from Kinjiro Amano. And I think this is for you, Hiro. What's the state of development of a vaccine in Japan? Any collaboration with China or South Korea?
Well, I have to say that the R&D for vaccine development is somehow behind from other countries such as US and UK and Germany. Japanese development will be coming perhaps the second half of next year rather than the first half. We have determined to import vaccines from UK and US for the first round of immunization next year. But I would say that we'll be working with the producers, manufacturers, and researchers in the UK and other European countries and US. But I'm not sure whether we have a specific collaboration with China or South Korea or Russia.
Okay. We're going to pick up on now something you said, Patrick, which is how critical it is for data systems to be in good shape for vaccine rollout. This is a question from Ellis Otway. It's directed towards Hiro, but I think you can both answer this. Your thoughts on data infrastructure needs for vaccine rollout processes. Patrick, as you brought this up quite strongly, do you want to start with that? What do we need and what's at stake here and what could go wrong?
So I think we need a very coordinated, internationally similar way of collecting data on everyone who's been vaccinated. So we need to know who's been vaccinated, with which vaccine, and when. We need to know some details of those individuals, and we need to know their course over subsequent years. I mean, so any side effects, obviously, for pharmacovigilance need to be looked at, but also things like, does reinfection occur? When does reinfection occur? What's the evidence that vaccination reduces transmissibility? Because we know that the vaccines reduce symptomatic disease and look very good at protecting severe disease and probably death. We don't know yet to what degree they prevent transmission of virus. And so only by collecting the information, linking that to contact tracing, to healthcare systems, to being able to analyze the effects as different age groups and different cohorts get vaccinated, will we understand the impact. So there is basic data requirements and then lots of data linkage behind that, because the other sources of data are held in different places. And I think there needs to be some standardization as to how this is going to be collected.
And is that a big challenge? That sounds pretty straightforward, like the health system's job anyway. Is that a particularly daunting task, or should we be in good shape to do this?
Well, I mean, in a way, it's very straightforward. But of course, these things never are when you're talking about tens of millions of people all being vaccinated in different places across the country at different times, and ensuring that you get the appropriate linkage between primary, secondary healthcare records and all of that. They're not straightforward things to get right, but they are. The concept is easy, and therefore there are bits of it that ought to be straightforward. But I think this is going to be quite a challenge.
And we're on it. Are we on it?
Well, I think we're on it. As far as, we've raised it, and it's been, people know what needs to happen. But there's a very big difference between knowing what needs to happen and in practice making sure everything does happen like that.
Yeah. So Hero, what's your perspective on the data infrastructure that's going to be needed for vaccine rollout?
I completely agree with Patrick, because most vaccines need 2 shots. So we need to identify who got the shot when, which vaccine, because some vaccine need 2 weeks interval and some vaccine need 3 weeks interval. And we also need to have the follow-up system, because we don't know 100% sure about the safety of the vaccination. So we have to have the very strong infrastructure of the vaccination. And in addition, we do need to have the very low temperature to contain the vaccine, minus 70 degrees or 28 degrees. So we have to have the information system about the dissemination or supply chain of the vaccine. I think that's very important for the distribution of vaccines and administration of vaccines.
Well, that's a very good one to end on. We're coming close. We've got 2 minutes left. So sounds like there's a lot at stake, and the vaccine rollout will be a very good test of how we manage our data systems. But I wanted to give you both an opportunity for some parting shots on this whole issue of data sharing, information sharing, and systems in getting us through the rest of this pandemic. So Hero, I'd like to invite you to go first as what are your parting shots, take homes for the audience and for us?
Thank you. For the most part, we have discussed about the vital statistics and data today. But at the same time, I think we need to have the data on the very important materials such as PPE, personal protective equipment, because in May or April this year, we have a very big shortage of supply, masks and gowns and gloves. That was the very important issues for hospitals. So we have to have the data in terms of the supply, level of supply and stockage of this type of equipment. So in addition to the vital statistics, we have to have this type of material statistics as well. That's my lesson. Thank you.
Patrick.
Yeah, I think 2 things really. One is that there needs to be, I think, an open societal discussion around data sharing and privacy and security of data, because many of the things that would be very helpful are related to issues of privacy. And so I think there needs to be an open discussion around that. And the second is that we've talked about data, but a lot of this is about analytics. And I think there ought to be an absolute requirement on code sharing for analytics.
Okay. Well, thank you both very much. And wow, 9:30 on the dot. So I've been very good. Normally I do tend to push it a bit. So I'd like to thank you both so much for great insight and a great back and forth between you. So I think we got a lot out of that. And it sounds like there's a lot of work to do still on data sharing into pandemic and during this pandemic, still a lot to iron out. So thank you both for your insights and thoughts on this. And thank you to the audience for tuning in, and wishing you all a good day the rest of the day. Thank you so much.
Thanks.
Thank you, Emma. Thank you, Patrick.